we don't have a specific focus this week as we sometimes do, although if we had to think of what we are going to spend most of our time talking about, it probably is going to be about trust and transparency, but that's an enduring theme. As usual, though, we'll start with a roundup of the very latest facts and figures, and then the whole panel will take questions from our special guests and the press and members of the public who are here as well. You're all special, though. But here with the facts and figures then is Professor Christina Pargle. Christina, over to you.
Right. Hi, everyone. So the numbers today. So basically, the kind of headline is that there are some positive signs, but there's a lot of regional variation. And so I suspect that coming out of restrictions will be hard. And I think we're seeing that in Europe as well, that it's difficult to relax restrictions safely. So the order today, I'm going to start with hospitalizations because that kind of helps put the figures on deaths into perspective, into context, and then kind of dig in a bit to cases by nation and region, and then just have a couple of slides on the international context, which I think is really useful if we're thinking about what next, before summarizing. So hospitalizations, this is comparing the different nations. Now, remember, Wales can't be directly compared because they include suspected admissions where the other nations don't. And this is the 7-day daily average of number of daily admissions to hospital per million people. So it is normalized to population. Wales had its fire break on the 23rd of October. So it certainly has stopped their admissions increasing, but they haven't yet really started to come down. Whereas Northern Ireland and Scotland are both now seeing what look like sustained decreases in hospital admissions, which is a really good thing. Although there's just this slight uptick in Scotland over the last couple of days, but that could just be, an artifact. In England, what we saw was a kind of a slowdown towards the end of October, beginning of November, probably, well, maybe because of half term, I don't know. And then we actually saw a reasonably rapid increase over the beginning of November, but now it's starting to slow down again. So if we look a bit closer at England, you can see that plateau here about 2 weeks ago. And that will be relevant when we look at reported deaths, because basically deaths that are reported now, a lot of those people would have been in hospital, admitted hospital during this period. We then saw this increase, but then this week we have seen a drop again in hospital admissions. And I hope that these will keep coming down over the next couple of weeks. But they're still high. We're still getting, 1,500 admissions a day in England. And what that means is that the number of people in hospital is continuing to go up. So this is where we were last week, and this is where we are now, almost at 14,000 people in hospital right now in England. And so we're only about 3,000 short of where we were at peak in April. So, it is quite important that admissions do start to come down in England so that the NHS doesn't get overwhelmed. And then, as well as hospitalizations, occupancy in critical care in England is still going up. And so just thinking about that plateau we saw in admissions a couple of weeks ago, because ICU occupancy and hospitalizations are still going up, it's likely that will still translate into some more people dying over the next week or so. But hopefully, as admissions drop, these numbers will start to come down soon. So looking at deaths, this is from the death registrations where COVID is on the death certificate. This is still going up. This is up to the 6th of November. So remember, this is quite lagged data, but we're still on the 2-week doubling up to the 6th of November. So, but we should start to see that slow down next week, I hope. And just to kind of say that although this is any death where COVID is mentioned, about 90% of those actually say that COVID was the direct cause of death. So these are genuinely deaths because someone caught COVID. If we look at the England daily deaths by reported date, that is starting to slow down a little, and you can see this week that the increase has stopped. So this is kind of now a plateau, which is the good news, but I suspect it might have more to do with the fact that hospital admissions plateaued about 2 weeks ago. But we'll see over the next week, and hopefully even if they go up a little bit, because hospital admissions went up a little bit, hopefully they will start coming down consistently within a week. So looking at cases, this is the kind of overall UK numbers by reported date. And remember last week, we just had this massive spike of 33,000 cases, which were all in England. It does look as if this is a kind of a pre-lockdown socializing spike in England, because we have not seen those numbers sustained. And that is really good news. I mean, obviously it's not great that we had that spike, but it's much better to have a spike than it is to have a big increase continuing on. So case numbers are kind of back to where they were at the beginning of November. But of course, there's a lot of national variation, there's a lot of regional variation, so we should really be looking at that. So when we're comparing different nations and different regions, you have to take population size into account. So this is the number of new cases per week per 100,000 people. And now, as I did last week, I've switched to what's called specimen date. So that's the date that someone had a test. So it's more closely related to when they got sick than the date it was reported, because it can take anything from a day to 5, 6, 7 days for a test result to be reported. But because of that time it takes to report it, you can only look up to about 5 days ago. So the most recent data just isn't reliable. So this goes up to the 14th of November. But it's a much better way of looking at the impact of any kind of new restrictions. So if we look at Scotland, again, this is when they started restrictions in the Central Belt. This is when their 5-tier system went in, and they've just moved some new places into level 4. But they've basically been pretty stable for the last month. But it does look as if their positivity rates are coming down. So part of this is that they're testing more. So that's not a bad thing. That's a good thing. And the Office of National Statistics today says that, that it looks like for the last 2-3 weeks that the proportion of people in Scotland testing positive has come down. So it is decreasing there, but it is incredibly regional in Scotland. So they now have 4 levels, 4 levels that different regions are in. This is kind of the map of the different levels, where this is the least restrictive and this dark color is the most restrictive. And this is the positivity rate, so the proportion of people testing positive over time since September for each of on average over each of those areas. And you can just see that the areas with the strongest restrictions have by far the highest positivity rate of over 8%. Not far off twice what the next highest level is. And there is you can see why the different levels are in their different restriction levels, because they do genuinely have different levels of infection. All of the positivity rates are stable except level 4, where it looks like they are slowly coming down, which is a good thing. I'm guessing that that the reason that these regions went up to level 4 is just because these are really high rates, and you really do want to get that down. And so they've got more stringent restrictions now to try and get cases there down to a much lower level. Northern Ireland had its circuit breaker in the middle of October. Schools were shut for 2 weeks. They opened beginning of November, but everything else is shut. They've seen a kind of a big decline in cases, which has plateaued in that most previous week to the 14th of November. But again, the Office of National Statistics thinks that positivity rates there are coming down. So that's a good thing. So it looks like Northern Ireland is still on a good trajectory, although it started off from a pretty bad place. So it's still got a way left to go. And what's also interesting in Northern Ireland, as you can see now that, they're still in lockdown, but schools open, is that while at the beginning of November, end of October, everywhere was going down, which is just places in blue. Now you are seeing more regional differences where some places are starting to increase again. And for instance, Fermanagh and Omagh had 60% increase in the week to the 14th of November. So this is something that I'm imagining the Northern Ireland will want to keep a close eye on. Wales had its fire break end of October. Cases there are coming down. And again, we're seeing that in our statistics. So that's really good. But they they ended their fire break about, 10 days ago, roughly. And so kind of seeing whether that has an impact and whether they can keep the cases going down is going to be key over the next week or so. And finally, England had its tier system. Cases still went up. Started lockdown on the 5th of November, cases still going up. But it looks as if this going up is because we are testing more, genuinely testing more. And so looking at positivity rates from ONS, it looks like they are stabilising. And we also saw that in Public Health England data that actually the proportion of people testing positive has stayed the same this week. So it's kind of saying, okay, well, we're testing more people, so we're finding more cases. However, the problem with England is that almost it's really regional. So what's happening is that the Northwest is coming down and has been coming down quite significantly since the end of October. Yorkshire's coming down a little bit, and everywhere else is still going up. And that's quite worrying. And you see something similar if you look at the positivity rate. So if we just remove these top 4 places, you can see that kind of the southeast, southwest, east of England and London are all still going up quite a lot. Now, this is 9 days after lockdown. But if we don't see these numbers come down next week, we should worry. Because really, we can't keep going up in all areas apart from the north. The other issue with England is mass testing, where they're using what are called lateral flow tests to test lots of people, regardless of whether they have symptoms or not. And at the moment, you can see the number of these tests here in red. So at the moment, there's still a really tiny proportion of all the tests, so they're not going to be affecting the numbers too much. But as these mass testing programs are rolled out across England, and 67 local authorities have signed up to it, if we keep reporting them all together, people who have tests because of symptoms and people who are mass testing, it means that we cannot really interpret trends and we can't really interpret positivity rates. So it's going to be really, really important for the government to start reporting these results separately. So I just really hope they do, because as these the rapid tests that are used for mass testing, as they become more used, it's going to be a real issue to try and understand what the hell's going on. So that's just what that says. And just one slide on test and trace. Oh, hang on. How do I? This is from this lovely dashboard by iSense, but basically nothing has changed over the last few weeks. We're still only reaching 60% of close contacts. It's still much worse for centralized systems compared to the local systems, which are reaching 99% of cases. So there's no sign that the system is being improved during lockdown to enable a safer exit. And that's an issue. And I don't know if you saw, the BBC had a big documentary about it last night, but essentially test and trace isn't working well enough and it's not getting any better. And that remains a problem. So just 2 quick slides on the international context. So there are some countries that have very similar lockdowns to what we're having right now. So these are 5 countries, France, Czechia, Netherlands, Belgium, and Ireland. Where there's a solid bar, they have closed schools. And where it's a dash bar, they have kept schools open. Some of them were already starting to see a decrease in cases before they locked down. So like Belgium, and the Netherlands. The Netherlands had a long period of restrictions on hospitality beforehand. But you can see that where they've closed schools, they have seen really steep decreases that have been sustained for several weeks. France hasn't closed schools, but it does have mandatory mask wearing by all pupils. That they are now starting to see bigger decreases in cases. Ireland has had kind of quite steady decreases since the end of October, but they also started off, with much lower case numbers. So they never got anywhere near as bad as, say, Belgium or Czechia. And there are some countries that haven't locked down, and they're trying different kind of combinations of restrictions, regional curfews, closing some sectors and not others. So Germany has closed hospitality, gyms and cinemas, but shops are open, schools are open, and they've slowed down their case growth, but they haven't yet turned it around and come back down again. Spain has been having issues for a long time. They have a mix of curfews and regional restrictions, but they are now starting to see cases coming down over several weeks. Switzerland is quite interesting because they had the massive spike at the end of October, and they implemented some restrictions middle October and then the end of October, and they're now starting to see cases coming down, but they're more kind of equivalent to our tier 3, but they do seem to be having an effect there. And this is Italy, where they have a regional system actually very similar to Scotland, where the maximum level is equivalent to what our lockdown now. And they have slowed case growth, but they haven't reversed it. So what I'm just trying to say is that it is very complicated to work out, okay, what do we need? Like, we know that lockdowns seem to work everywhere, but how do we come out of lockdown in a way that keeps cases coming down? And different countries are trying different things, and different things will work in different countries because the culture is different, the way people respond to restrictions is different, the ability to mix indoors and outdoors is different, inequality is different. But I think we have to try and learn from each other as we're planning the next steps. So just to summarize, case numbers are coming down or they're stable, but there is a lot of regional variation, and especially in England, where all of our reductions basically concentrated in the Northwest and Yorkshire and Humber. The recent spike in cases that we saw in England is actually most likely due to pre-lockdown socialising, and that's a good thing. It doesn't look to be sustained into this week. But it will be really concerning if cases don't start coming down in England by next Friday. We really do want to start kind of a sustained decrease, and it has to speed up. And it will speed up if the other regions that aren't the north start coming down. Because if we want to be in a place where it's safer to relax restrictions by beginning of December, then we need to get cases down a lot more than they are now. And the direction of travel in Northern Ireland, Wales and Scotland is also really important as the countries are kind of, the nations are experimenting with, how do we keep things in check, but allow more freedoms. So I think basically coming out of restrictions is really difficult to manage. So just a quick word on schools. I haven't discussed it much this week, but the kind of headline is that cases are continuing to go up in school-aged children under 16. But a lot of that is due to more testing. They are getting more tests, so the positivity rates aren't changing that much. ONS infection survey does show that primary school-age children are still having cases going up. But we are going to focus more on schools next Friday. So come back and find out all about schools then. And yeah, that's it.
Thank you so much, Christina. It's great to have that comparison with what's going on in different countries as well, because it's like we have all these separate case studies. We are going to go straight into questions now, and I would like to invite Nigel Nelson to ask the first question. Nigel Nelson is political editor of the Sunday Mirror. Welcome, Nigel. What's your question?
Hi, thanks very much, Alice. Yeah, it's to do with Christmas, which is a bit confusing at the moment, that PHE seems to be suggesting that if we open up for 5 days over Christmas, that would mean basically a complete lockdown in January. So for every 1 day we're unlocked, we add 5 days of lockdown. The two questions really are, do those figures sound about right to you? And secondly, is that what we should be doing?
So who would like to take one of these? I don't normally allow 2 questions in one, Nigel, but as you're starting, I'll forgive you.
One question in 2 parts.
Who would like to start with that one? Stephen, I'm wondering if you might want to.
Okay, well, a couple of points. I mean, first of all, I think it would be mad to give absolute guarantees because we don't know what state we'll be in as Christmas approaches. And if the infections were extremely high, if the NHS was in danger of being overwhelmed, if literally, people with heart attacks couldn't be taken to hospital because the hospitals were full, it would be ridiculous then to do things which increase the rate of restrictions. So the first point to be made is that we need to get the infections low. And the way to get infections low, of course, is to have clear, strong restrictions and for people to abide by those. If people don't abide by them now, then the chances of being able to do anything at Christmas are much reduced. So that's the first thing. I think an absolute guarantee now is just irresponsible in many ways. The second thing is that the effects of people mixing at Christmas are very much contingent not only on how much they mix, but how safe they are and how much they observe the mitigations we all know that are important. So, for instance, keeping physical distance, ventilation, very important, and hygiene. And I think one of the things we need to think about when it becomes safe to mix in the home, and I say when, and as I say, that's contingent upon level of infection, is we put much more emphasis on domestic transmission, and we put much more emphasis on how to keep the home safe and that the government supports us. So, for instance, ventilation is very important. There should be a government ventilation scheme, just as there used to be an insulation scheme. If people are to be able to stay warm and be ventilated, then they need to use fuel. So there should be a pandemic fuel allowance for the poor, in the same way that we have a winter fuel allowance. So we need to help people to understand how to keep their homes safe, and the government needs to support us in keeping homes safe. But the final point I want to make is this, that when we talk about Christmas and the Christmas spirit, then the Christmas spirit, as I understand it, is it's about family, it's about gifts, it's about keeping people safe. And the last thing you want to do at Christmas, the worst gift you can give anybody at Christmas, is to infect them and to endanger them, especially your elderly relatives. And I think people do understand that. So as I say, I think for me, for Christmas, the key issues are, let's get the infection rate low before Christmas, and then there may be a possibility of mixing. And secondly, let's pivot much more towards an emphasis on domestic safety and on helping people. I like to call it supported regulation. Let the government help people to do things to keep themselves safe and to keep their families safe and to keep their communities safe.
Thank you very much, Stephen. That's Professor Stephen Reicher. And Dr. Zubaida Haque, I think you wanted to come in on that question as well.
Well, I very much endorse what Stephen was saying, but I think what I'd like to add is, lockdown is only one of the outcomes of having Christmas for 5 days and 1 month lockdown, because the other much more devastating outcome is, of course, the impact on those who are vulnerable. And just to quantify that, we have some 12 to 20 million people in this country who have some kind of underlying illness or are vulnerable in one way or another. I mean, there's extremely high proportions, about 1 in 5 people in this country who have some kind of vulnerability. So we can't just think about the extremely vulnerable, it's also about the moderately vulnerable. But that, of course, raises the question of who exactly is Christmas therefore for? And I think we need to keep that in mind, that lockdown is just one of the consequences. The other consequence, as Steve has rightly raised, is, of course, serious illness and death.
Thank you very much. We've got another person. Carl, Professor Carl Friston would like to respond to this one as well.
Yeah, just the 1 day out, 5 days in rule. It's a very difficult question to answer, because you'd like to answer it from the point of view of the evidence base, and we just don't know. So I've spent the morning on Google trying to find out where this evidence comes from, and have failed. So it would be useful if the journalists could actually press the sources of this this meme to find out exactly what the assumptions are. In terms of what's likely to happen, I'm wondering whether this kind of rule, which is a very attractive little meme to propagate around the media, maybe a slight misdirection. So if you remember the beginning of Christina's presentation, it's going to be a long haul. We're going to come out of this slowly, and that's commonsensical because we're in partial lockdown. Therefore, we're not attenuating viral transmission in as quick a way or an effective way as we did in the first wave. So it's going to take much longer to come out of this. So we're talking now months, not weeks. So if you're asking, is it true that there's going to be an enduring, persistent social distancing after Christmas? Absolutely. I'm not so sure it's useful to have little trade-offs between inside and outside. I think those issues are probably best dealt with in a principled way in terms of the good practice and the risk to you personally and what you should be doing that Steve's just rehearsed for us.
And Dr. Kit Yates wants to answer this question as well. Kit.
Hi. Yeah, I just wanted to echo Carl's thoughts really and suggest that it's not clear what the current R value is yet. It's not clear what it would be if we were to release restrictions and how they would be released. So there are a range of different R values which could accommodate this 1 versus 5 day trade-off for before and after a lockdown. But how we know what those actually are is difficult to find out. And so it'd be interesting to know where they come from. The other thing that I want to emphasize is that quite apart from the fact that this 25-day potential lockdown would make for one of the most depressing Januaries ever, which is obviously already a depressing month, the calculation only accounts for the fact that we're trying to bring cases back down, and it sort of neglects the fact that actually cases bring hospitalizations, and hospitalizations bring deaths with them. So there is almost certainly a cost for if we relax restrictions and say, let you mix with whoever you like for as long as you like. There has to be sensible limits, and similarly to what Steve was saying, we need to press the best ways to meet safely, wearing masks, being outdoors, social distancing, ventilation. All of these aspects need to be encouraged if we are going to allow people to meet over Christmas.
Thank you so much, Kit. Now moving on to the next question, and it is coming from Robin Andrews from Devon. Robin, are you there?
I'm here. Can you hear me and see me?
Yes, we can.
Okay, I'm a little bit challenged about what to ask because there's so many things I want to ask. But I have this ongoing general concern about the quality of reasoning within this whole issue. So I used to be a maths teacher, and I know a little bit about statistics and sampling and stuff like this. And so one thing that's really struck me is that we're counting case numbers without referencing the number of tests made. And this is a statistical error which even Donald Trump didn't make. He's not known for his mental acuity, but he understood that if you make more tests, then you're going to show up more cases. So I know that you just showed us earlier on this, proportion of tests, a proportion of people, which is a good metric. But the media aren't using that. They're just quoting absolute numbers of positive tests to the nearest integer, as if that was some kind of meaningful way of measuring the spread of the virus. So that's one aspect. And the other aspect is cause and correlation. So I think one of the reasons that a lot of people don't like this 28-day within testing positive metric for the deaths is that really that's talking about correlation. It's not talking about cause. So you could just as likely say that actually the test was killing people unless you had more information. It's that wide a ballpark of how wide that error can be. And that error also applies to whether or not lockdown works. So we're assuming that these measures are having an effect, but there's absolutely no guarantee that that's the case. So I want to know what safeguards there are, what kind of reasoning, quality control of reasoning is in place. That's one aspect. And the other aspect is in terms of reporting. Like, for example, saying that there's been X number of COVID deaths, that's simply not true. It's an approximation based on a whole load of assumptions. So how can those figures be permitted to be quoted by media and by government as representative of the situation? So there's a few questions there, but the kind of overarching question is quality control of your reasoning, particularly do lockdowns work? How do you know?
Thanks very much, Robin. I think for that one, I'm going to go straight to our resident mathematician, Dr. Kit Yates again.
Thank you.
Hi, Robin. So I guess I can answer a little bit about how we look at the statistics. So certainly in terms of cases, you're right. Cases without looking at increases in testing don't paint the full picture. So it's important to look at the proportion of positivity as Christina and I do each week. We try to present that. In terms of deaths, and I think this is true across all statistics, it's important to look at different ways of gathering these data and making sure that they're consistent with each other. So there are different ways to calculate deaths, for example. So at the moment, we use figures from Public Health England, or at least the government uses figures from Public Health England, which have a 28-day cutoff. And certainly there will be a small number of people who get COVID, recover from COVID, and then die of some unrelated cause within 28 days. But this is actually is a relatively small number. And we know that because we can compare it against other data sources. In fact, there are probably more people who get a positive test and then go on to die of COVID after 28 days. So in fact, the 28-day figure is probably an underrepresentation. Certainly earlier on in the epidemic in the UK, when many people weren't getting a COVID test before succumbing to the disease, the 28-day metric was certainly underestimating the number of deaths then. A more reliable indicator, I think, is probably looking at people who have COVID registered on their death certificates. The ONS keeps track of these figures, and they indeed do suggest that the 28-day cutoff is an underestimate. So this is slightly lagged because it takes a while for deaths to be registered. So there's a reason why the 28-day figure might be preferred, because it's more up to date. And there's actually evidence to suggest that the 60-day cutoff is perhaps more in tune with the deaths. The other way of measuring is excess deaths, all-cause mortality. So thinking about what impact this pandemic has had overall, but of course, so there we're comparing the number of deaths that we have this year to maybe the 5-year average, and what that doesn't tell you is what the causes of those deaths are. So we do need to go back to things like death certificates and when people have died after a test in order to get a fuller picture. But I'd say that generally, when thinking about data, trying to get multiple sources out there which agree with each other, which confirm what each other is saying, gives you more confidence, but never certainty in exactly what the data is saying.
Thank you very much. I'd like to go to Professor Carl Friston first, and then Sir David will come to you. Carl had his hand up earlier, that's why.
So great question. Alice said we have plenty of time to answer questions, so I'll try and I'll just take on two of the key questions. What reasoning is behind this? The reasoning that we use is slightly different from a lot of the reasoning that is used by people like the SBIM and SAGE, in the sense that many of the recommendations that we make are based upon modeling that is explicitly evidence-based. So literally, it's the evidence or the likelihood of the data given a model. And that's important because that means you can score different models of what is happening and what is likely to happen. And when you do that, you need to have what's called a generative model, which resolves the second issue brought to the table, which is this sort of cause correlation issue. So if you can write down a model of how the data are caused, then in principle, you can resolve all these issues. And the two, an interesting issue, which actually, again, Christina touched upon, and we have actually discussed before, not only is the headline numbers that you see on the media uninterpretable unless you know exactly how many tests were performed that day, and can give you a very misleading picture. Even the positivity rate is also misleading, because people are more likely to come forward if they're infected or symptomatic. Therefore, you've got biased sampling, even in terms of positivity. So that's from the technical point of view, that's a really important question, which speaks to having an understanding of the way that the data are generated. So if you wanted to go and look at the way that we deal with that, then you'll find links to the UCL DCM website in the Independent SAGE website.
Can I just come back to you on that, just very quickly, Cole? Presumably, those data, even though they're incomplete and essentially a sample each time, and not a very adequate sample, presumably they're still good for spotting trends.
Absolutely. I mean, the data are essential. So you use the data to inform what you think are causing those data. So any data is great. And the more different kinds of data you can use, the more precise and the better your estimates will be. I think Robin's point was more, should we just eyeball these data and pursue our intuitions, or should we actually formally evaluate the models that are trying to explain those data and then base our analysis of trends and predictions on the inferred, which comes equipped with measures of uncertainty? That can be done, that has been done. We have referred to that kind of modeling in the past, and my suspicion is we will see a move towards that kind of modeling over the forthcoming months or years.
So David King, you wanted to respond to that question as well.
Very quickly, all I want to say is, yes, on the one hand, there's modeling and statistics, and on the other hand, there's scientific understanding. And if you just go back in the history of disease control, this is highly infectious diseases. We've had isolation wards in hospital dealing with this for more than 100 years. And that is the way to contain an epidemic. If you isolate the people who have the virus and they either die or they develop the antibodies, then the virus has nowhere to go. It needs healthy people to spread. So the idea of a lockdown is a very blunt instrument. It's not something anyone would advise in handling a disease. We would say the better process is test, trace, and isolate those who've got the disease from the healthy population. But here we are without a test, trace, isolate, and support system in place, and we've had to go into another lockdown. We know that the lockdown would work better, for example, if we weren't having children go back to school. If we actually operated a much tighter lockdown, then I think it's clear the epidemic would come down faster. But this is all a choice to be made on priorities. So I just want to insert a bit of science into the discussion. Thank you.
Thank you very much, Sir David. Now we're moving on to another question. And please, can I remind questioners to keep your questions short, and you're only allowed one question, not two or three. And the panel always know to keep their answers nice and concise and clear. They always do anyway. So the next questioner is Adam Vaughan from New Scientist. Adam, are you with us?
Hi, thanks, Alice. I'm not going to put my camera on because I've got a load of washing behind me, so I don't think you want to see that. My question is really the end of Christina's presentation at the start. I just wanted to sort of unpack a little bit. What are the key differences between European countries in determining how effective their lockdowns are proving? I.e., is it how early they're locked down, schools being shut or open? Is it the regional versus national? And also, how does that effectiveness of those lockdowns compare to the last round of lockdowns? I'm interested in how, what the comparison is with the March to May ones. So I've sort of snuck in two questions there, sorry.
Very sneaky. Professor Christina Pargle would like to take this.
Hi. So, I mean, that's such a good question, and it's what I try and work out every week just by looking at what's going on. But I think, well, the big differences are whether hospitality is shut or open. So it looks as if places that just close early, that's not particularly effective. And closing restaurants and bars does seem to slow things down, but in some places it's been enough to turn the corner, in other places it hasn't. I think one of the really big differences is household mixing. So everywhere's got quite different rules on who you're allowed to mix with and where. But it does seem to me that the places that have more strict household mixing rules are doing slightly better. But of course, what you never know is how much people adhere to the rules that they're given. So we know what the rules are in different places. What we don't know is how closely they're followed. And I think that makes everything that much more complicated. But I think we are seeing in all places that it's much harder for people in deprived communities or who have jobs that don't let them isolate at home very effectively.
Thank you. Professor Susan Mickey, I wondered if you wanted to comment on that question as well.
sorry, what aspect of the question were you thinking of?
I suppose more the kind of behavioural aspects of it.
Well, in terms of the household mixing and the adherence, I mean, it's a real problem because it's very difficult to get data. You know, we can only understand things to the extent that we can get data about what's actually happening. And things like hospitality being shut or open is something where one can get data on. The problem about household mixing, unless anybody else has got any ideas as to how it can be measured, is more problematic. On the question of the curfews not really adding anything compared to shutting down completely, I mean, that is very much a behavioural issue. And I think had the behavioural scientists been consulted in this country, we probably wouldn't have gone down that road, because one always has to look at knock-on effects or unintended consequences of any one strategy. So, you know, what is very likely to have happened is if people know that the evening's coming to an end at 10 or the evenings in the bars, then they may start the evening earlier. And also at 10 o'clock, people, as we know, have congregated not only in the streets, but quite likely congregating in smaller, possibly, and less safe places. So with all of these restrictions, one's got to think about not only the restrictions themselves, but also any knock-on effects of those restrictions.
Thank you, Susan. And Stephen, I think you wanted to comment on this one too.
Yeah. I mean, I think there are three sets of factors, very briefly. The first is, in a sense, the state of the nation before the pandemic. If we look at two countries in Europe that have done really well, if we look at Finland and Norway, we see that they haven't suffered from 10 years of austerity, that their classrooms, for instance, are roughly half the size of ours, so they can distance in their classrooms, and that their health services and numbers of beds haven't decreased. So that's the first factor. The second factor are the restrictions, and clearly there are many forms of restrictions. But the third factor, and this comes to the issue of behaviour and compliance, is very much linked up with trust, with the levels of trust. Those countries which have high levels of social trust, actually people go along with measures without necessarily having to make them compulsory. And one of the great problems we've got in this country has been the crisis of social trust. The difference between the first lockdown and the second lockdown isn't that people have become weaker and less able to put up with restrictions. They've lost trust. It's plummeted from 75% in early April to around 30% now. That's in England. It's different in Scotland. We've got a real crisis of the social contract, a real crisis of the bond between government and public. And one reason for that, of course, is the government doing things which suggest there's one law for them and one law for us. And we saw that again today. Boris Johnson tells us we mustn't bully, but if it's one of your ministers, you're allowed to bully. What does that say about them and us? So I think in the round, one of the critical issues, if we've got to get through this pandemic, is to restore that bond of social trust and for the government to stop having different ways of proceeding depending on who you are. And I think that reset of trust is every bit as important as all the resets around, for instance, the testing system and in terms of support for people.
Thank you very much, Stephen. Moving on to the next question, then please keep it nice and short. Alexandra Thompson from Yahoo. Alexandra.
Hello, I'm so sorry, I've got building work. I hope you can hear me. I just wanted to go seasonal again, but talk about New Year's Eve. We don't know yet whether pubs will be open, but young people particularly enjoy that celebration and they might perceive themselves as being at lower risk. So I hate to say, anecdotally, I know people who are planning on having house parties, whatever the restrictions may be. How do you think we can celebrate New Year's Eve this year? And what would be your message to young people who think they're immune?
I'm looking for somebody to answer that. And I'm wondering if, Gabriel, you might consider taking that question.
Waving.
Sorry?
No, I think, given it's about Hogmanay, it should be a Scotswoman that answers this, I think. Susan's got her hand up.
Yes.
Thank you.
Susan.
Susan.
Early upbringing. Well, I think one of the things to bear in mind is the spike that Christina showed us earlier about pre-lockdown socialising. And I think the socializing and socializing, it goes back to what we were talking about, safe Christmases with families being potentially a very different thing than at New Year's Eve celebrations. And what we don't want is to have not only that spike, but maybe a spike that's a couple of times as high as that. But on the other hand, you're right, people are already planning these things. They're planning the Christmases, they're planning their New Year's. So one thought is, given how much safer things are outdoors, a global database was showing that 95% plus of the kind of super spreading events were those that were indoors, and 3 or 4% outdoors. Maybe there could be a real encouragement for outdoor parties, but parties that could be obviously as distant as possible, with people wearing face masks, with hand sanitizer stations around the place. Now, will any of that work when large volumes of alcohol are consumed? Who knows? But I think it's got to be this sort of balance between, on the one hand, people getting together is going to increase transmission and is going to increase death at this point, with trying to engage with the reality of what people are likely to be doing anyway and how to manage that situation. So I would go outdoors as one potential part of the solution.
Thank you very much, Susan. I'm going to move straight on to the next question. We've got lots of questions to get through, so I want to rattle through a few more with great care, of course. The next one comes from Tom Magna of Carers World. Tom.
Thanks, Alice. It's about testing reliability. In Wales, for example, there are serious viewer concerns about false positives in symptom testing, and allied worries that a proven false positive indicates contamination in the specimen taking and/or testing process in the lab. So how much weight should be given to false results, whether positive or negative, in the presentation of scientific data and in national and local decision-making process? Thank you.
Thank you very much for that. I'm looking to who would be the best person to answer that. And Gabriel, you've got your hand up. So Professor Gabriel Scally,
I don't know about being the best person, but I think when it comes to the individual or the collective, there's a big difference. Clearly, it depends on the test and how accurate the test is, what the sensitivity and the specificity of the test are. That's really important, particularly if you're giving an individual advice. But when we're looking at the use of tests to guide positives, to guide policy, it probably is a much lesser effect. And so I have a lot of confidence in terms of the tests that guide policy, in terms of the big numbers, the sort of charts and plots that we present to you every Friday, or Christina and Kip present to you every Friday. Those will guide policy, I think, fairly well. When it comes to an individual, and particularly people perhaps at home or in a small institution, some of the tests are very accurate, and some of the tests will be done very well in those settings because they're being taken by people who have perhaps been trained or come from a clinical background and are able to take them well. There is a whole question about the handling of the tests, of course. And for those of you that saw the documentary about taking the tests and one of the companies and the way in which they were handled, it really didn't inspire confidence. And of course, we would, if we had a proper testing and tracing system with people running it who we felt we could trust, we could ask them this question with the hope of getting a decent answer, which is one of the reasons why we in Independence Age would like to see test and trace handed over to NHS England to do, so we could absolutely get some transparency on these key issues for individuals. Thank you.
Thank you very much, Gabriel. And now we have a few questions on the subject of vaccines, starting with Lucy Watson from London. Lucy.
Thank you. And also I want to say a big thank you for everyone for your great work over the last few months. My question is, we've heard lots of great news around how effective vaccines are at stopping us getting sick. But if I've understood correctly, we're less certain as to whether they work in terms of halting onward transmission. And if I've understood that rightly, that raises a big concern for me, because you're going to create a population of people who've been really fearful and cautious over the last 9 months, who are suddenly going out and being as active as they can within the rules. And we can't really see them because they'll be relatively asymptomatic. And that reminds me of the students, the role they played back in September and October. So do we risk creating essentially the fuel for wave 3, which, okay, may not be as lethal as waves 1 and 2, but you're still potentially going to have thousands of people who are middle-aged or younger generations getting long COVID and ruining lives and livelihoods. Should this be a concern? And if so, when will we get this information and how do we mitigate?
Professor Martin McKee, I think you'd like to take that one.
Oh, thank you very much indeed. Well, the evidence we have so far from the animal studies, anyway, from the studies in macaques with the vaccines that have been evaluated, does suggest, as you say, that they prevent people getting the serious consequences of infection, but not actually of becoming infected. Now, looking ahead in due course, if that is the case, then you would expect that people will still get the infection in their upper respiratory tract, and it will be that which will engender the so-called sterilizing immunity, which will stop onward transmission. So it will be a process rather than the act of vaccination itself. It is likely that the vaccines will provide some degree of protection against infection, but not that much. The difficulty is that the initial infections, the immune response is different. And that's why, for example, with influenza vaccine for children, it's given nasally, and that's primarily because it's to prevent children from passing it on to older relatives. And so we would like at some stage to perhaps consider having vaccines which might be administered in that way. And but there are, I think, 3 which are currently being developed, but they're not even in trials yet. That will be a long time down the road. So although it is potentially concerning that it won't stop the onward transmission, the vaccination itself may not stop the onward transmission, it is possible then that if people do get infected afterwards and they get exposed in their upper respiratory tract, they will get that sterilizing immunity that will lead ultimately to a break in transmission. But the really important thing is if it stops people dying, that's a huge advantage, of course. But it would be great. But very few vaccines that are injected do actually produce that upper respiratory tract immunity with IG, with particular immunoglobulins, IgA, and so on.
Thank you so much, Martin. And I think Dr. Talina Oni, you'd like to speak to that question as well.
Yes, just to add to, absolutely concur with Martin's response, and just to add to that, that when we're talking about a vaccine, we also remember that the vaccine doesn't protect, vaccination does. And so, we are in this process of actually then, we're talking about the efficacy and effectiveness of vaccine, but we also needs to be, we need to have this coverage that is done equitably. That's the first thing. And then the second is that these real challenges and issues that we will continue to face as we get vaccines that are effective in different ways in different populations, that is going to be a stage process. And until then, it's really important that we're not seeing the vaccine as, so do we get the vaccine? Has it started now? And can we go back to normal? But that it still forms part of the ammunition, if you like, that we have, which still involves what we know. We know a lot more about how the virus is transmitted. So the importance of distancing, the importance of mask wearing, where air exchange is poor, so indoors, etc. So it's really important that we see this, even when we do have a point where we say these are the vaccines that we know are effective in these population groups, etc., that we see that as part of a comprehensive package of infection control.
Thank you very much, Talila. Now we have 2 members of the GP committee for the Doctors Association UK joining us, and they'd like to each ask a question, so I think we can fit them in. The first comes from Dr. Vinesh Patel. Vinesh.
Thank you very much for having us. So my question is, we know that the government has invested in several different vaccines to ensure that in the UK we have access to the right ones as soon as it's approved and available. However, with the limited information on the research data that is currently being released, and with the date of the 1st of December to commence this program being less than 2 weeks away, patients are understandably asking us, are they going to be getting the right vaccine at the initial stage, or should they wait until approval on all the vaccines as things are developing so quickly within a matter of weeks? So this is something that clinicians are finding hard to answer, and the key to success, as I've mentioned, is trust. So data needs to be published, and we need to be have clear guidance from NHSC and the government. Do Independent Sage have an opinion on how we address the issue of multiple different vaccinations being available across varying timelines? And do you feel we need some clear communication strategy nationally before we start this program in December, recognizing the risk that delaying the start of the program will bring as well?
Professor Anthony Costello, I wondered if you'd like to comment on the vaccination program.
Gosh, I don't think I really am the best person. You know, at the moment, on the data I've seen, I'd probably go for the Dolly Parton vaccine because it's Dolly Parton. But we don't have the data. And the point you make, Vinesh, is extremely important. And to me, it seems incredibly early to be rushing out a mass vaccination program, although we're in a pandemic. And so there is this political push to, you know, do something to try and interrupt, because we have failed so badly with our test and trace system that has led to these soaring peaks compared to the countries that actually put in some proper prevention. So it's a good question. I mean, obviously, to be encouraging, the data of 90+% efficacy on very early findings is encouraging, but it does worry me a bit that rushing into something could lead to a potential disaster if there were to be very serious safety concerns. I haven't seen really any safety data yet. So it is a catch-22. I think December's too early. I think before Christmas is too early. I'm not sure when, does anyone know when the Oxford trial is going to report? Because that's a much bigger study and it's multi-country. And I thought that they were going to be reporting their findings before Christmas.
Yeah,
but
I think it's at Christmas.
Martin,
well,
you want to come in on this question as well?
First of all, the difficulty we have here is that the nature of vaccine production is that the companies do have to report for the stock markets to prevent insider trading and all sorts of other things. And then we have to get the papers in the peer-reviewed journals where we can look in more detail. And unfortunately, the reality is there are these two competing objectives. But of course, the portfolios will have to be submitted for approval, and the Pfizer one is being submitted today. So we should, and there has been a rolling review of the evidence anyway, so we should have that fairly soon. The difficulty is that we've got, I think, 148 vaccines in development at the minute, and 12 or so in phase 3 trials. So we can't wait, we would be waiting forever if we were to wait for all of them. Now there's about, of my calculations, about 7 that the UK has already had advance purchase agreements for 40 million doses of the Pfizer one, 5 million of the Moderna one, and 100 million of the AstraZeneca. Now, it will take time to scale those up. I have to say I'm rather less concerned than Anthony, because of course there's always a possibility of longer term consequences that we just can't know until time has passed. But remember that tens of thousands of people have been vaccinated already. And the difficulty until we do challenge trials, as is being done with the Janssen study, is that you need to vaccinate an awful lot of people to get even the number of cases we have, which now with the Pfizer case is about 180 cases, which was the pre-specified endpoint for the trial. So it was done absolutely per protocol. That was as agreed in advance as to what we would expect. So yeah, of course, we will need a monitoring and surveillance system, sort of so-called phase 4, to follow up for any consequences. But I am a little bit more relaxed. I think the challenges are going to be the logistics of getting this out, because as Tola has said, it's not the vaccines that save lives, it's the vaccination program.
Thank you, Martin. And sorry, Christina, I apologise if I talked over you. I think you were just saying that you were expecting the results of that Oxford vaccine by Christmas.
Yeah, I was just agreeing with Anthony that I heard Oxford would be reporting by Christmas, end of the year. Yeah.
Thank you.
Sorry for interrupting everyone. I'm jumping.
Fine. So the next question is from Dr. Elizabeth Tobberty, also of the Doctors Association. Elizabeth, are you there?
Yes, can you hear me? Yeah.
Yes, we can. Yeah, go ahead.
So I am also a GP, and we've just touched on the logistics of the vaccine. I've got big concerns over the rollout, the practicalities of the COVID-19 vaccine and our capacity within primary care to deliver it, and that what may be sacrificed is chronic disease management. We're already seeing some excess deaths, mortality and also morbidity in relation to some of our chronic disease management not being done. I wondered, in terms of the COVID-19 vaccine rollout, does any of one at independent stage share our concerns over that and what is being sacrificed within primary care in order to deliver it, and whether they would have any suggestions on improvements and strategy for the COVID-19 vaccine rollout in order to both provide that service but also protect our patient population from non-COVID causes of death as well.
Thank you very much for that question. Zubaida, I wondered if you wanted to comment on that.
Yes and no. I want to, this isn't about the vaccine as such. I think one of the things I want to say is I feel that our focus on the find, test, trace, isolate and support programme is dissipating. I feel that particularly that the media have also sort of changed their focus onto the vaccine. And I know why we're all focusing on the vaccine. As Anthony Costello has rightly pointed out, you know, it's because the government have spectacularly failed with the find, test, trace and isolate programme that everybody is pinning their hopes on the vaccine. But it's not here yet. So I feel that we need to still concentrate on what we know works, and what we know works is the test, trace and isolate programme. And going back to Adam's point from the Economist, it's not just about the visible measures, the lockdowns that matter. It's also about the invisible measures. And one of the invisible measures that's wholly failing, that we really need to fix, is the support for self-isolation. There is no point in mass testing or anything else unless we support self-isolation. So I feel we need to go back to that.
Anthony, I know you wanted to come in on that question about vaccines, and then I think we'll move on because I want to squeeze in another couple of questions. Anthony.
Very quickly, in answer to Elizabeth's question about, basically about overload of GPs. I mean, GPs have done a fantastic job this year, completely transforming primary care services and, you know, backing up an awful lot of conditions that in previous years would have gone to hospital. And they're understandably nervous about, you know, taking on test, trace and isolate, or taking on a whole massive, the biggest immunization program in history. And I share that view, but I think it should be linked in the same way that find, test and trace and isolate would have done much better if they had had primary care people at the table and primary care networks helping with it and with proper financial support helping to deliver it. But I think you're right, you can't just depend upon GPs to deliver all of these vaccines as quickly as we want. I think there is talk of having other centres and also bringing in a lot of retired staff who could help with the vaccination programme, you know, at weekends and evenings and the like. But I think general practice is the backbone of the NHS, and they are the people that should be consulted first about how they're going to do it, and it will be region specific, but they'll need a lot more support.
Thank you very much, Anthony. I'm going to move on to another question now. Jane Hershey from Bristol. Jane, are you there?
Yes, I'm here. Can you see me now?
Yes, we can see and hear you. Go ahead.
Okay, great. Hi. Yes, so I had a question. It was about the rollout of the vaccines. I'm speaking as my husband is a secondary school teacher, and he's also on the clinically extremely vulnerable list, as are quite a few of his colleagues in other schools. Obviously, keeping schools open is a priority, and schools are really struggling with staffing levels. So sort of taking that into account, I was wondering whether or not you think teachers should also be on the priority list in terms of rolling out the vaccinations.
So should teachers be on that priority list? Gabriel?
I think the general issue you raise is an important one about prioritisation. And the Joint Committee on Vaccination and Immunisation produced, I think it was in September, their draft priority list. And I think it requires some more discussion because it doesn't really deal with occupational issues beyond health and social care, NHS and health and social care staff. And that needs to be considered. For example, some of the occupational groups who've had quite a high incidence of death, like transport workers, bus drivers. All of those issues need to be considered. And it is notable that in other places, I remember particularly New York, the state of New York, and their priority list has people who work in grocery stores and transit workers right up the second priority group for the vaccine. So I think, firstly, I think we do need to look at priority listing, and teachers would obviously be for consideration as part of that. But I'm unaware of the evidence yet about teachers' mortality, occupational mortality so far. But there is another more general issue, I think, about the use of the vaccine geographically as well, because we know that there are some local authorities who have been particularly hard hit. Those local authorities, particularly in the Greater Manchester area, where you've got three factors coming together: high levels of deprivation, high levels of overcrowded housing, and a high proportion of BME population within those local authorities. And I think there is a need for a geographical emphasis as well. And I know of local authorities where there are wards where no one has had COVID. No one has been reported as having any positive tests, and they are the most prosperous wards. And so I think we need to be thinking, if, as it looks like, we're going to get a slow feed of the vaccine, how exactly we use it is a question that the JCVI needs to come back to with help from other experts to advise them on the issues that need to be taken into account. Thank you.
Thank you, Gabriel. And I know, Martin, you wanted to quickly comment on this.
I would really want to emphasize what Gabriel said. The JCVI document is very much focused on protecting those who are most vulnerable themselves, and it really says nothing about the role of those who might spread infection or those who are in the front line, facing public-facing roles. In France, for example, they, as well as in New York, they have included all the public transport workers, retail workers, and others. And I think that there's a very strong case for revisiting that. But even more important than that is that I think we absolutely need to have somebody explain clearly how this is all going to be done, because we're hearing about large vaccination centres being set up and so on. And the priorities the JCVI have are people in care homes, then the over 80s, the over 75s working down, and how those groups are going to be identified, how they're going to be brought to be taken to the vaccination centres if they need to get there. There are a huge number of questions, as well as all the logistics of distributing the vaccine. So I think we really don't want to see a repeat of what happened with testing and with tracing, where all of this is handed to some company that has no idea how to do it. And unfortunately, at the minute, I just don't know. I don't have the confidence that we're going to be able to do it until we actually see somebody with a flip chart and a flow chart and who can tell us who is responsible for what, because at the minute we just don't know.
That seems to be a problem which repeats and repeats, Martin, and this seems to be an issue with transparency. And you know, when we hear scientists saying that they're not confident, I think that is extremely worrying for how we're dealing with the strategy in the future. I'm going to move on now to our last question. So this is from Hannah Doit from Leicestershire. Hannah, are you with us?
Yes, hello. Thank you so much for the opportunity to ask a question. I just really welcome your insights on the current plans to move students home for Christmas and offer them tests before they move. I'm interested in whether you think the test being offered is appropriate for a screening test in people that are not symptomatic, and is there a risk it will offer a false sense of security? Thank you.
Susan, I wonder if you would like to take that. Do you think that students are being offered a full sense of security here?
Well, I was actually going to hand it over to Steve, because I think Steve knows more about this than I do.
Well, it's a pity we don't have Liz Stoker with us here, because she led on our papers on universities. So I will try and be channel Liz if I can. I think what's been suggested is a step in the right direction, but I'm extremely worried that it's, in a sense, too little too late. And what we've consistently argued is that there should be a shift to online teaching as the default. That would then allow us to do a number of things. First of all, it would allow us to stagger the return back home. And at the moment, they talk about it being staggered, but they talk about it being staggered within 1 week, and that's no staggering at all, and it isn't particularly protective. Secondly, there should be testing, I think, for people to go home, but it's still not clear exactly how that's going to happen, whether it's really merely advisory or not. And more seriously, there's no talk about when students come back again to campus. And thirdly, the implication is that students should come back to campus. Now, if you move to online teaching, then students could have the choice. Some might want to come back to campus, some might want to stay at home. That would allow you to have halls that were less full, and therefore there would be less danger of spread. And so I think we've seen some small move in the right direction, but I think we need a much more comprehensive shift towards a policy which kept students safe and staff safe and the community safe. And the reason why this is happening, I think, goes back in a way to the marketization of universities, and the fact that universities are scared of losing students, and in a sense are in the same position as pub landlords. They don't want to lose custom. And I think that these safe policies are really important, and I think vice-chancellors and principals should be supported with funding from the government so they can do the right thing for public health. Because if they don't, they're caught between a rock and a hard place and are really concerned about actually collapsing. So as I say, we need to support universities to support students to keep all of us safe.
Thank you, Stephen. And Tallulah, I know that you wanted to comment on that too.
Yes, I'm going to make a comment that links both this comment on university students and the earlier questions around vaccinations, which is the plea for 2 steps ahead thinking. So, you know, we often very much focused on the actionable and what's happening now, which is understandable. But the reason why it is important that we simultaneously thinking 2 steps ahead is because of 2 things: unintended consequences and issues around equity. So this happens both in the context of universities. If we're not thinking 2 steps ahead and thinking, rather than simply just let's get them home and let's just hope, you know, we know a lot more now, so hopefully things will be better and we'll figure it out when we get back. That has several issues, not just because we're not thinking about potential unintended consequences around students that are either vulnerable themselves, students who are homeless, students who are living with vulnerable people, students who so there's so many different considerations in terms of unintended consequences, and those have a strong equity dimension. So if we don't simultaneously think the 1 and 2 steps ahead, we stand the risk of widening that equity gap. And the same applies to when we talk about vaccination. So we're talking about the susceptibility and prioritization around that, and the importance of thinking about vulnerability, but also around exposure. The third dimension, which we haven't mentioned so far, which is important, is also connection and access to care. We are in danger of making the same mistakes around communication and engaging the public that we had around the messaging on the first lockdown, when we found that even though the messaging was clear around stay at home, Steve can speak to this, there were huge parts of the population that that message hadn't permeated. So on one hand, yes, there are logistical issues around the vaccine, but if we're not the time, there's concern about when should we be acting, when should we be implementing. The one thing we definitely need to be doing now with the vaccine is engaging and the public and that participation to understand what the critical issues are, how to avoid, how to consider potential unintended consequences, how to address those, so that the implementation of vaccines that eventually get approved do so in a way that address inequity. So that was just the point.
Thank you very much, and an incredibly important point to end on. It is time to wrap up for today, but I'd like to invite Sir David King to sum up as usual. Sir David.
Couldn't possibly sum up all of the important discussions that have been had, but what I am going to say is that this meeting was an illustration of how to get trust established between the scientific community and the public. And this, of course, has been missing from the government's SAGE committees. This is really why Independent SAGE was set up. What I hope you've seen is that when you get a group of world experts together, as you've seen here, you get really well-considered answers to your questions. But the other side to this is that we as a committee are also finding that we're learning from these questions from the public. So it's a two-way process, and that, I believe, is what is missing from the SAGE process. Thank you very much.
Thank you very much, Sir David. Thank you to all of our panel. Thank you to everybody who's been watching. All the reports that have been published by Independent SAGE are available on the website, along with details of the whole team as well. Do follow Independent SAGE on Twitter if you don't already. We'll be back same time, same place next Friday. Have a good weekend. Stay safe. Keep well. Thank you, everyone.
Thank you, everybody. Bye.
Bye.